Hello all. In this session, we discuss about the antiarrhythmic drugs. Antiarrhythmic drugs either suppress the initiating mechanism or they can block the delayed after or early after depolarization or they can alter the re-entrance circuit. When we are using antiarrhythmic drug, we must consider the pro-arrhythmic potential of those drugs. Most of the antiarrhythmic drugs have ability to generate a different types of arrhythmia. Just by altering a conduction rate, they may produce other type of arrhythmia. So that precaution should be taken while using antiarrhythmic drugs. The general mechanism of action of antiarrhythmic drugs, they produce their action by altering automaticity in a pacemaker tissue. So this drug can slow a automatic rhythm by altering there are four different mechanisms, so they can alter those mechanisms. One of the mechanism is they can decrease the slope of phase 4. Here you can see that the slope of phase 4 if slightly reduced, we can increase a gap between two action potential. So this type of action is achieved by using a beta blocker like drug. Second mechanism, just to increase a threshold potential. Here, if threshold potential is slightly increased, we can delay the development of action potential. So, uh, threshold potential can be increased by using drugs like sodium and calcium channel blockers. Third mechanism is to increasing a maximum diastolic potential. When we can say that increasing a maximum diastolic potential, if membrane is hyperpolarized, it will take time to reach to a threshold potential and we can delay the development of action potential. So the gap between two action potential is enhanced by using drugs like adenosine. Fourth mechanism is if we can increase action potential duration. If total action potential duration, or we can say that if we can enhance the effective refractory period of the tissue, we can delay the development of action potential. So mainly the repolarization, if we can interrupt the repolarization by using a potassium channel blocker, we can enhance the effective refractory period as well as we can enhance the total action potential duration. So these are the four mechanisms through which we can suppress the automaticity. There are two ways to increase the refractoriness. Here you can see that this is a phase 1, 2 and this is a phase 3. Here you can see that at this point almost 25% of sodium channel are now in a recovered state. That means they are able to propagate the impulse and they are likely to generate a early after depolarization. If we are using a sodium channel blockers, this sodium channel blockers can also block the prolong the inactive state of sodium channel, and we can see that you can shift this point towards this point, and by shifting this point we can enhance the effective refractory period of the tissue. Similarly, without blocking a sodium channel, if we can increase the action potential duration, suppose in a normally this is a action potential, if we are using a potassium channel blockers, they can enhance the repolarization total action potential duration as well as the effective refractory period can be increased. So these are the two ways through which we can increase the refractoriness of the tissue and we can prevent development of early as well as a delayed after depolarization. As there are four different class of drugs used for treatment of arrhythmia. First we discuss about the class 1. The class 1 antiarrhythmic agent interfere with the activity of sodium channel. Thus all of these drugs can decrease the slope of phase 0. More frequently the sodium channels are open, that means the more greater will be the blockage by this drug. So we can say that the action of class 1 drugs are known as an use dependent action. They can be further classified as a class 1A, class 1B, and class 1C. That classification is basically based on the action of on a potassium channel. Some of the drugs having ability to open up the to open up the potassium channel, as well as some of them having ability to block the potassium channel. So on the basis of that, they were further classified. First group, class 1A, they block open and inactive state of sodium channel. So they block the sodium channel in open state. That means the phase 0 or the slope of phase 0 is slightly reduced. So this drug can also block the cardiac potassium channel. Blockage of this potassium channel, we can enhance the total action potential duration, we can enhance the effective refractory periods. So both the action were generated with the class 1A, block the sodium channel, reduce the slope of phase 0, and enhance the effective refractory period by blocking a potassium channel. When we can say that effective refractory period is enhanced or repolarization is prolonged, we can say that QT interval is also be prolonged with the class 1A drug. When QT interval is prolonged, there is a chance for a development of Tosa's D point. This is another type of arrhythmia. So, class 1A drug having a pro-arrhythmic potential by just enhancing a action potential duration. Two congener, quinidine and procainamide. Quinidine is a derivative of cinchona plant, as we know that it is an anti-malarial group of drugs. Its anti-malarial action is less in comparison with the quinine, but its adverse effect produced with the quinidine, they are known as an cinchonism. Additional action are associated with the quinidine, like it also having antivagal action, so produce anticholinergic side effects. At higher dose, it also inhibit the calcium channel, and it also having weak alpha blocking property, so they are able to produce hypotensive effect. The use of quinidine, they are rarely used. They what we can say that they are helpful to maintain a sinus rhythm after termination of atrial fibrillation or atrial flutter. Another congener is procainamide. It is an orally active derivative of local anesthetic procaine. Its action is opposite to quinine, that it having less antivagal action. So there is no any anticholinergic side effects were observed. It doesn't block a alpha receptor, so no hypotensive effect is produced. So it is helpful to terminate a ventricular tachycardia by intravenous administration, but we can say that it is less effective in the prevention of recurrence. So only acute attack is terminated by using procainamide. Second group, class 1B, they block the inactive state of sodium channel. So class 1B antiarrhythmic agent are sodium channel blocker that also possess a potassium channel opening property. So it is opposite to class 1A. They block it, while class 1B, they can open up the potassium channel. So by blocking sodium channel, the slope of phase 0 is reduced, as well as effective refractory period and action potential duration is also reduced with the class 1A, class 1B blockers. Two congener, one is lidocaine and maxillatine. Lidocaine is the most commonly used local anesthetic agent. It has a very high fast pass metabolizing effect. So it is administered only by intravenous route of administration. It is the drug of choice for a treatment of ventricular tachycardia in case of emergency like acute myocardial infarction or during cardiac surgery. There is a chance to alter a ventricular rate. So to control that, lignocaine is a drug of choice. Another congener is maxillatine, is orally active lignocaine congener. It it's property is almost as similar as a lignocaine. It reduces the automaticity in a Purkinje fiber. So it reduces the slope of phase 4. Being a orally active congener, it is used for control a ventricular tachycardia over a longer period of time. Then the class 1C, which block, what we can say, they are the most potent sodium channel blocker. They block open state of sodium channel only, and here you can see that there is a more reduction of slope of phase 0, as well as they doesn't having any action on a potassium channel, so the action potential duration or effective refractory period is not altered because of class 1C. These drugs have a maximum proarrhythmic property. Therefore, they are indicated only for a resistant and a life-threatening ventricular tachycardia or a ventricular fibrillation, and for a treatment of some refractory supraventricular tachycardia. So, for a resistant cases, these drugs will be helpful. The reason for that is they having proarrhythmic potential. Congener is Propafenone. It can delay the conduction as well as block the anterograde and retrograde conduction. So have ability to block re-entrant type of arrhythmia. Additional mechanism is also block a beta receptor, but it having high proarrhythmic potential, and it may leads to development of sudden death. So, due to this effect, it is a reserved drug for a reentrant tachycardia only in case of resistant cases. Class 2, they are known as a beta blocker. They act by blocking beta 1 receptor, thereby decreasing a sympathetic activity on a heart. This drug are useful in a treatment of supraventricular tachycardia. They decrease a slope of phase 4, which is responsible for a automaticity, as well as it also reduces the conduction rate in a AV node. There are various beta blockers are there, but those which are used for a treatment of arrhythmia like esmolol, sotalol and metoprolol. Esmolol is a short-acting beta blocker. It can be used intravenously for emergency control of ventricular rate in atrial fibrillation or atrial flutter, while metoprolol can be administered by oral or intravenous route. Sotalol being a beta blocker, as well as it also having additional action to increase the action potential duration by blocking delayed potassium current. So action potential duration can also be enhanced with the sotalol. Beta blockers are helpful to a number of different types of arrhythmia. The reason for that is they having less proarrhythmic potential. They are used for a ventricular and atrial arrhythmia. They can be used for acute supraventricular tachycardia or after cardiac surgery to maintain a cardiac rate. Beta blockers are the first drug of choice. Third group, the antiarrhythmic drugs, class 3, they predominantly block the potassium channel. By blockage of potassium channel, we can say that we are prolonging a repolarization and prolonging a total action potential duration. So this is like a class 1A drug. They can also prolong a action potential duration. Class 3 drug can also prolong the action potential duration. So they are likely to produce a Tosser's D point because of prolongation of QT interval. There are different congener. One of them is Amiodarone. It is a longest acting class 3 drug. Its plasma half-life is 54 days. It also having action on all the class of antiarrhythmic drugs, like it also block the sodium channel, block beta receptor, having potassium channel blockage and calcium channel blocking property. It decreases the SN node automaticity and AV node conduction. Due to this property, it is used for the wide variety of arrhythmias. Is Dronedarone. It is similar to Amiodarone. Its plasma half-life is shorter, that is 1 day. There is another congener is sotalol. Though it is a beta blocker, but it having additional property to block a potassium channel. So being it is indicated for a treatment of various type of atrial and ventricular tachyarrhythmias, and they are helpful to block the AV node reiterated circuit in a different types of arrhythmia. Other newer congeners like abutylite, it is structurally almost similar to a sotalol, but it doesn't having beta blocking property. So it is used for a treatment of atrial fibrillation or atrial flutter by intravenous route of administration. And dofetilide is a class 3 drug which is administered by oral route. So for a long-term maintenance, dofetilide is the preferred one. So they can be helpful for a different types of arrhythmia, ventricular or supraventricular arrhythmias, resistant ventricular tachycardia, recurrent ventricular fibrillation, maintenance of sinus rhythm in atrial fibrillation, or a long-term prophylactic therapy. Class 3 drugs are helpful. And class 4, they are known as an calcium channel blockers. They block a L type of voltage gated calcium channel. They decrease a rate of phase 4 depolarization in a SA and AV node. This result in a decrease in the automaticity of SA node, as well as they can decrease the conduction through AV node. So they have the ability on a phase 0, action on a phase 0, they have an action on a phase 4, or they also having a slight action on an effective refractory period. The congener like verapamil and diltiazem, they are mainly indicated for a treatment of paroxysmal supraventricular tachycardia to control a ventricular rate in atrial fibrillation and in atrial flutter. So this is all about the different types of antiarrhythmic drugs. Now some treatment part for some important arrhythmia. Drugs for a treatment of PSVT, paroxysmal supraventricular tachycardia. Verapamil and diltiazem is the drug of choice for a PSVT. It terminates acute attack by intravenous route of administration within a 2 to 3 minutes. It is able to control a rate. To prevent recurrence, it is administered by orally. So the advantage of calcium channel blocker is that they are helpful to terminate acute attack as well as they are helpful for a long-term maintenance. But drawback is that they, being a calcium channel blocker, they may produce AV block and a bradycardia. Another drug is adenosine. Adenosine opens the potassium channel and leads to a hyperpolarization of AV node. It is a drug which produces hyperpolarization through blockage of adenosine 1 receptor. It is a drug of choice for a treatment of PSVT. It is what we can see that its action is very short acting drug. Its plasma half-life is only a 10 second, and additionally it also depresses the re-entrance circuit through AV node by indirect blocking a calcium current. So the two actions were generated with the adenosine. Various advantages are associated when it is used for a treatment of PSVT. Its efficacy is better than the verapamil, as well as its action is lasts for less than 1 minute. So when we can say the action is lasts for less than 1 minute, adverse effects are also a short lasting, and therefore it cannot alter any hemodynamic deterioration. Also having disadvantages like it produces transient dyspnea, as well as its plasma half-life is very shorter. It is not suitable for the recurrent cases. Now, the drugs for atrial fibrillation. For a treatment of atrial fibrillation, first to revert a abnormal rhythm back to a sinus rhythm and then control a ventricular rate. Abnormal rhythm is reversed by using a drugs like propafenone, flecainide, sotalol or dofetilide. While ventricular rate is controlled by digoxin, beta blockers and a calcium channel blockers. Digitalis is the drug of choice for controlling a ventricular rate in atrial fibrillation, whether it is associated with a congestive heart failure or not. Digitalis is not capable of curing a atrial fibrillation. The main function of digitalis is to control a ventricular rate. Digoxin can be used for controlling a ventricular rate in a patient with atrial fibrillation with a cardiac failure by increasing a force of contraction, as well as it reduces a ventricular rate in atrial fibrillation by decreasing a number of impulses that are able to pass through AV node by increasing a effective refractory period of AV node by its vagomimetic action. The, the therapeutic endpoint of digitalis therapy is what we can say that the dose adjustment of digitalis is to be achieved on the basis of ventricular rate. So we have to achieve a ventricular rate in between 17 to 80 beats per minute at rest. If the ventricular rate is not achieved to a normal by digitalis alone, we have to administer beta blocker or verapamil to control a ventricular rate. And additionally, for a treatment of atrial fibrillation, anticoagulant like drugs are necessary because digoxin is not indicated in a patient with a atrial fibrillation with a normal ventricular rate. In such patient, warfarin is indicated to prevent a development of stroke, particularly in presence of risk factors such as a history of transient ischemic attack. The reason for that being a uh, increasing a atrial rate, the pumping efficiency of atria is reduced, and due to that blood is passively from flow from atria to a ventricle. There is a sluggish movement of the blood. There is a chance of blood clot. So to prevent development of stroke like effect, anticoagulant are administered for a treatment of atrial fibrillation. And lastly, all these drugs which we have discussed, they are used for a treatment of tachyarrhythmias. Now the drugs used for a bradyarrhythmias or a drugs for a AV block. Atropine, which is an anticholinergic drug, and the sympathomimetic, both are able to use for a treatment of AV block. The reason for that, they can increase the AV node conduction velocity. If impulse are rapidly passed on through AV node, their ventricular stimulation capacity is increased, as well as those drugs can also decrease the AV node effective refractory period. So if effective refractory period is reduced, conduction rate can also be increased. So both the group of drugs, atropine and sympathomimetic drugs, are helpful for a treatment of AV block, and they can prevent development of first degree, second degree or third degree AV block. So this is all about the antiarrhythmic drug. Now how to choose a antiarrhythmic drugs. The selection of antiarrhythmic drug is based first on the correct diagnosis, which type of arrhythmia is there. Second, the urgency of treatment, whether it is an acute case or it is required a maintenance therapy or it required for prevention of recurrence. So on the basis of that, you have to select a drug. Then on the basis of route of administration, they are selected. In case of emergency, they were used by intravenous administration. And for maintenance therapy, you can select those drugs which are given by oral administration. As well as the main selection is based on a risk benefit ratio of those drugs. Most of the antiarrhythmic drugs having a potential of pro-arrhythmic potential, so they are likely to produce different types of arrhythmia. So for a long-term maintenance, you have to select a drug which having more beneficial effect and less pro-arrhythmic potential. This is all about the antiarrhythmic drugs. This is just a brief outline of all the antiarrhythmic drugs which are used for treatment of different types of arrhythmias. That's all. Thank you.